Hello, I am Dr. Patrick Lydon, Professor of Neuroscience at the University of California, San Diego Medical Center, and staff physician at the VA Medical Center. I'll be giving you basic instruction in examining and scoring patients using the NINDS-NIH stroke scale. After each set of demonstration and scoring instructions, I will guide you through some subtleties we've learned over the years. If that's helpful to you, feel free to click on the Special Features section of the menu page. They are excerpts from interviews with other stroke scale experts who provide excellent tips on scoring various items. First, let's discuss important general guidelines and ideal conditions for giving the exam. The value of stroke scale assessments depends on uniform examiner-patient interactions. Anyone who gives the exam needs to stick closely to the testing and scoring methods to ensure reliability and reproducibility of the results. Remember, the stroke scale is designed to measure the deficits seen in a group of patients, so some of the scoring rules may seem odd to you as experienced clinicians. If you follow these scoring rules, then the reliability of scores obtained in varying places by different examiners will be very comparable. All scale items must be scored. Record a score for each scale item before going on to the next one. If any item is left untested, a detailed explanation must be clearly written on your stroke scale form. It is important to use only the validated form available from the NIH. In the package you received with this disc, several websites are listed where you may download the correct version of the scale. Generally, we record the patient's first effort, even if follow-up efforts are better, to optimize the reproducibility of the scoring. Don't go back and change scores. The most reproducible score will be your first impression. Work methodically and quickly. An experienced examiner will be able to complete the NIH stroke scale evaluation in about 5 minutes for uncomplicated cases, though a difficult patient may require a bit more time. Each scale item is judged independently from the previous items. There are some exceptions, and we'll highlight those as we go. Now here are some important conventions used to assure the excellent reproducibility of the NIH stroke scale. Administer the scale items in their exact order. Avoid coaching the patient, even though this may be counter to usual clinical practice of trying to elicit the best performance. Accept the patient's first effort. Score only what the patient does, not what you think they can do. During the course of testing, you may develop an impression of level of function or lesion. Those impressions must not influence your scoring. Again, score only observed performance. Sometimes these rules don't make sense, but if all examiners do the scale the same way, the scores will be consistent. Be sure to include all deficits in your scoring, including those deficits that may result from previous strokes. Not all decisions are simple. When you're having trouble deciding on a score, try ruling out the extreme score and then weigh the mid-scale scores. You should keep the stroke scale reference material, such as the scoring guide, nearby when you administer and score the NIH stroke scale. However, at the bedside in a critical situation, all you need is the proper scoring sheet, the naming sheets, and a pin. These are the overall conventions. Now let's focus on each item of the scale. I will describe and perform each item of the scale for you and then go over scoring.